Linking on my brain. Okay. Linking on my brain. I got linking on my brain. Whoa.
Introduction. Out of 206 total bones in man, the upper limbs contain as many as 64 bones. Each side consists of 32 bones, the distribution of which is shown in Table 1.2, and the individual bones of the upper limb will be described one by one. Their features and attachments should be read with the bones before undertaking the dissection of the part concerned. The paragraphs on attachments should be revised when the dissection of a particular region has been completed. The clavicle, Latin small key, is a long bone. It supports the shoulder so that the arm can swing clearly away from the trunk. The clavicle transmits the weight of the limb to the sternum. The bone has a cylindrical part called the shaft, and two ends, lateral and medial. Side determination. The side to which a clavicle belongs can be determined from the following characters. L. The lateral end is flat, and the medial end is large and quadrilateral. 2. The shaft is slightly curved, so that it is convex forwards in its medial 2/3, and concave forwards in its lateral 1/3. 3. The inferior surface is grooved longitudinally in its middle 1/3. Peculiarities of the clavicle. 1. It is the only long bone that lies horizontally. 2. It is subcutaneous throughout. 3. It is the first bone to start ossifying. 4. It is the only long bone which ossifies in membrane. 5. It is the only long bone which has two primary centers of ossification. 6. There is no medullary cavity. 7. It is occasionally pierced by the middle supraclavicular nerve. It receives weight of upper limb via lateral 1/3 through Coracohumeral Ligament and transmits weight of upper limb to the axial skeletal via medial 2/3 part. Features. Shaft. The shaft is divisible into the lateral 1/3 and the medial 2/3. The lateral 1/3 of the sham is flattened from above downwards. It has two borders, anterior and posterior. The anterior border is concave forwards. The posterior border is convex backwards. This part of the bone has two surfaces, superior and inferior. The superior surface is subcutaneous and the inferior surface presents an elevation called the conoid, Greek cone, tubercle, and a ridge called the trapezoid ridge. The medial 2/3 of the shaft is rounded and is said to have four surfaces. The anterior surface is convex forwards. The posterior surface is smooth. The superior surface is rough in its medial part. The inferior surface has a rough oval impression at the medial end. The lateral half of this surface has a longitudinal subclarian groove. The nutrient foramen lies at the lateral end of the groove. Lateral and medial ends. 1. The lateral ot acromial, Greek peak of shoulder, end is flattened from above downwards. It bears a facet that articulates with the acromion process of the scapula to form the acromioclavicular joint. The medial or sternal end is quadrangular and articulates with the clavicular notch of the manubrium sterni to form the sternoclavicular joint. The articular surface extends to the inferior aspect, for articulation with the first costal cartilage. Evolution of upper limbs. The forelimbs have evolved from the pectoral fins of fishes. In tetrapods, terrestrial vertebrates, all the forelimbs are used for supporting body weight, and for locomotion. In arboreal, tree-dwelling, human ancestors, the forelimbs have been set free from their weight-bearing function. The forelimbs, thus emancipated, acquired a wide range of mobility and were used for prehension or grasping, feeling, picking, holding, sorting, breaking, fighting, etc. These functions became possible only after necessary structural modifications such as the following were done: appearance of joints permitting rotatory movements of the forearms, described as supination and pronation, as a result of which food could be picked up and taken to the mouth. Addition of the clavicle, which has evolved with the function of prehension. Rotation of the thumb through 90 degrees, so that it can be opposed to other digits for grasping. Appropriate changes for free mobility of the fingers and hand. The primitive pentadactyl limb of amphibians, terminating in 5 digits, has persisted through force transmission. Evolution and is seen in man. In some other species, however, the limbs are altogether lost, as in snakes, while in others the digits are reduced in number as in ungulates. The habit of brachiation, i.e. suspending the body by the arms, in anthropoid apes resulted in disproportionate lengthening of the forearms, and also in elongation of the palm and fingers. Study of anatomy. In studying the anatomy of any region by dissection, it is usual to begin by studying features of the skin, the superficial fascia and its contents, and the deep fascia. This is followed by the study of the muscles of the region, and finally, the blood vessels and nerves. These descriptions should be read only after the part has been dissected with the help of the steps of dissection provided in the book. Before undertaking the study of any part of the body, it is essential for the students to acquire some knowledge on the bones of the region. It is for this reason that a chapter on bones, osteology, is given at the beginning of each section. While reading the chapter, the students should palpate the various parts of bones on themselves. The next chapter must be studied with the help of loose human bones. Attachments. 2. At the lateral end, the margin of the articular surface for its acromioclavicular joint gives attachment to the joint capsu. 3. At the medial end, the margin of the articular surface for the sternum gives attachment to a fibrous capsule of sternoclavicule joint all around. Articular disc posterior-superiorly. Interclavicular ligament superiorly. 4. Lateral 1/3 of shaft. The anterior border gives origin to the deltoid. 5. The posterior border provides insertion to the trapezius. Attachment to the clavipectoral fascia. The posterior surface close to medial end gives origin to sternohyoid muscle. The subclavian vessels and cords of brachial plexus pass towards the axilla lying between the inferior surface of the clavicle and upper surface of first rib. Subclavius muscle acts as a cushion. The nutrient foramen transmits a branch of the suprascapular artery. Ossification the clavicle is the first bone in the body to ossify. Except for its medial end, it ossifies in membrane. It ossifies from 2 primary centers and 1 secondary center. The 2 primary centers appear in the shaft between the 5th and 6th weeks of intrauterine life, and fuse about the 45th day. The secondary center for the medial end appears during 15-17 years, and fuses with the shaft during 21-22 years. Occasionally there may be a secondary center for the acromial end. The clavicle is commonly fractured by falling on the outstretched hand, indirect violence. The most common site of fracture is the junction between the 2 curvatures of the bone, which is the weakest point. The lateral fragment is displaced downwards by the weight of the limb as trapezius muscle alone is unable to support the weight of upper limb. The clavicle may be congenitally absent or imperfectly developed in a disease called cleidocranial dysogiosis. In this condition, the shoulders droop, and can be approximated anteriorly in front of the chest. The scapula, Latin shoulder, is a thigh bone placed on the posterolateral aspect of the thoracic cage. The scapula has 2 surfaces, 3 borders, 3 angles, and 3 processes. Side determination. 1. The lateral or glenoid, Greek shallow form, angle is large and bears the glenoid cavity. 2. The dorsal surface is convex and is divided by the triangular spine into the supraspinous and infraspinous fossae. The costal surface is occupied by the concave subscapular fossa to fit on the convex chest wall, Figs 2.6 and 2.7. 3. The thickest lateral border runs from the glenoid cavity above to the anterior angle below. Features. Surface. 1. The costal surface or subscapular fossa is concave and is directed medially and forwards. It is marked by 3 longitudinal ridges. Another thick ridge adjoins the lateral border. This part of the bone is almost rod-like. It acts as a lever for the action of the serratus anterior in overhead abduction of the arm. 2. The dorsal surface gives attachment to the spine of the scapula, which divides the surface into a smaller supraspinatus fossa and a larger infrapinatus fossa. The two fossae are connected by the spinoglenoid notch situated lateral to the roof of the spine. Borders. 1. The superior border is thin and shorter. Near the root of the coracoid process it presents the suprascapular notch. 2. The lateral border is thick. At the upper end it presents the infraglenoid tubercle. 2. The medial border is thin. It extends from the superior angle to the inferior angle. Angles. 1. The superior angle is covered by the trapezius. 2. The inferior angle is covered by the latissimus dorsi. It moves forwards round the chest when the arm is abducted. 3. The lateral or glenoid angle is broad and bears the glenoid cavity or fossa, which is directed forwards, laterally, and slightly upwards. Processes. 1. The spine or spinofloes process is a triangular plate of bone with 3 borders and 2 surfaces. It divides the dorsal surface of the scapula into the supraspinous and infraspinous fossae. Its posterior border is called the crest of the spine. The crest has upper and lower lips. 2. The acromion has 2 borders, medial and lateral, 2 surfaces, superior and inferior, and a facet for the clavicle. 3. The coracoid, Greek like a crow's beak, process is directed forwards and slightly laterally. It is bent and finger-like. It is atavistic type of epiphysis. Attachments. 1. The multipennate subscapularis arises from the medial 2/3 of the subscapular fossa. 2. The supraspine floes arises from the medial 2/3 of the supraspinous fossa including the upper surface of the spine. 3. The infraspinatus arises from the medial 2/3 of the infraspinous fossa, including the lower surface of the spine. 4. The deltoid artery arises from the lower border of the crest of the spine and from the lateral border of the acromion. The acromial fibers are multipennate. 5. The trapezius is inserted into the upper border of the crest of the spine and into the medial border of the acromion, Fig. 2.10. The serratus anterior is inserted along the medial border of the costal surface, 1 digitation from the superior angle to the root of spine, 2 digitations to the medial border, and 5 digitations to the inferior angle. The long head of the biceps brachii arises from the supraglenoid tubercle, and the short head from the lateral part of the tip of the coracoid process. The Cotasia brachialis arises from the medial part of the tip of the coracoid process. 9. The Pectoralis Major is inserted into the medial border and superior surface of the coracoid process. 10. The long head of the triceps hierarchii arises from the infraglenoid tubercle. The teres minor arises from the upper 2/3 of the rough strip on the dorsal surface along the lateral border. The teres major arises from the lower 1/3 of the rough strip on the dorsal aspect of the lateral border. The senator scapulae is inserted along the dorsal aspect of the medial border from the superior angle up to the root of the spine. The rhomboid minor is inserted into the medial border, dorsal aspect, opposite the root of the spine. The rhomboid major is inserted into the medial border dorsal aspect, between the root of the spine and the inferior angle. The inferior belly of the omohyoid arises from the upper border near the suprascapular notch. The margin of the glenoid cavity gives attachment to the capsule of the shoulder joint and to the glenoidal labrum, Latin lip. The margin of the facet on the medial aspect of the acromion gives attachment to the capsule of the acromioclavicular joint. The coracohumeral ligament is attached, a, to the lateral border of the coracoid process, and, b, to the medial side of the tip of the acromion process. The coracohumeral ligament is attached to the root of the coracoid process. The coracoclavicular ligament is attached to the coracoid process, the trapezoid part on the superior aspect, and the conoid part near the root. The transverse ligament bridges across the suprascapular notch and converts it into a foramen which transmits the suprascapular nerve. The suprascapular vessels lie above the ligament. The spinoglenoid ligamenti may bridge the spinoglenoid notch. The suprascapular vessels and nerve pass deep to it. The scapula ossifies from 1 primary center and 7 secondary centers. The primary center appears near the glenoid cavity during the 8th week of development. The first secondary center appears in the middle of the coracoid process during the 1st year and fuses by the 15th year. The subcoracoid center appears in the root of the coracoid process during the 10th year and fuses by the 16th to 18th years. The other centers, including two for the acromion, one for the lower 2/3 of the margin of the glenoid cavity, one for the medial border and one for the inferior angle, appear at puberty and fuse by the 25th year. The fact of practical importance is concerned with the acromion. If the two centers appearing for acromion fail to unite, it may be interpreted as a fracture on radiological examination. In such cases, a radiograph of the opposite acromion will mostly reveal similar failure of union. Paralysis of the serratus anterior causes winging of the scapula. The medial border of the bone becomes unduly prominent, and the arm cannot be abducted beyond 90 degrees. Features: the scaphoid scapula is a developmental anomaly, in which the medial border is concave. 1. The head is directed medially, backwards, and upwards. It articulates with the glenoid cavity of the scapula to form the shoulder joint. The head forms about 1/3 of a sphere and is much larger than the glenoid cavity. 2. The line separating the head from the rest of the upper end is called the anatomical neck. 3. The lesser tubercle, Latin ICMP, is an elevation on the anterior aspect of the upper end. 4. The greater tubercle is an elevation that forms the lateral part of the upper end. Its posterior aspect is marked by 3 impressions: upper, middle and lower. The intertubercular sulcus or bicipital groove separates the lesser tubercle medially from the anterior part of the greater tubercle. The sulcus has medial and lateral lips that represent downward prolongations of the lesser and greater tubercles. 6. The narrow line separating the upper end of the humerus from the shaft is called the surgical neck. 7. Morphological neck lies 0.5 cm above surgical neck, shows the position of epiphyseal line, Fig 2.14. Shaft. The shaft is rounded in the upper half and triangular in the lower half. It has 3 borders and 3 surfaces. Humerus. The humerus is the bone of the arm. It is the longest bone of the upper limb. It has an upper end, a lower end and a shaft. Side determination. 1. The upper end is rounded to form the head. The lower end is expanded from side to side and flattened from before backwards. 2. The head is directed medially, upwards, and backwards. 3. The lesser tubercle projects from the front of the upper end and is limited laterally by the intertubercular sulcus or bicipital groove. Borders. 1. The upper 1/3 of the anterior border forms the lateral lip of the intertubercular sulcus. In its middle part, it forms the anterior margin of the deltoid tuberosity. The lower half of the anterior border is smooth and rounded. 2. The lateral border is prominent only at the lower end where it forms the lateral supracondylar ridge. In the upper part, it is barely traceable up to the posterior surface of the greater tubercle. In the middle part, it is interrupted by the radial or spiral groove. 3. The upper part of the medial border forms the medial 1IP of the intertubercular sulcus. About its middle it presents a rough strip. It is continuous below with the radial supracondylar ridge. Surfaces. 1. The anterolateral surface lies between the anterior and lateral borders. The upper half of this surface is covered by the deltoid. A little above the middle it is marked by a V-shaped deltoid, Greek triangular shaped, tuberosity. Behind the deltoid tuberosity the Rodin/groove runs downwards and forwards across the surface. 2. The anteromedial surface lies between the anterior and medial borders. Its upper 1/3 is narrow and forms the floor of the intertubercular sulcus. A nutrient foramen is seen on this surface in its middle, near the medial border. 2. The lateral epicondyle is smaller than the medial epicondyle. Its anterolateral part has a muscular impression. 3. The sharp lateral margin just above the lower end is called the lateral supracondylar ridge. 4. The medial supracondylar ridge is a similar ridge on the medial side. 5. The coronoid fossa is a depression just above the anterior aspect of the trochlea. It accommodates the coronoid process of the ulna when the elbow is flexed. 6. The radial fossa is a depression present just above the anterior aspect of the capitulum. It accommodates the head of the radius when the elbow is flexed. 7. The Olecranon, Greek ulna head, fossa lies just above the posterior aspect of the trochnea. It accommodates the olecranon process of the ulna when the elbow is extended. 8. Attachments. 1. The multipennate suprascapularis is inserted into the lesser tubercle. 1. The suprascapularis is inserted into the uppermost impression on the greater tubercle. 2. The infraspiniphilis is inserted into the middle impression on the greater tubercle. The teres minor is inserted into the lower impression on the greater tubercle. 6. 5. The pectoralis major is inserted into the lateral lip of the intertubercular sulcus. The insertion is hilaminar. 7. The latissimus dorsi is inserted into the floor of the intertubercular sulcus. 8. The furs major is inserted into the medial lip of the intertubercular sulcus. 9. The content of the intertubercular sulcus are, the tendon of the long head of the biceps brachii, and its synovial sheath. The ascending branch of the anterior circumflex humeral artery. 9. The deltoid is inserted into the deltoid tuberosity. 10. The coracobrachialis is inserted into the rough area on the middle of the medial border. 11. The brachialis arises from the lower halves of the anteromedial and anterolateral surfaces of the shaft. Part of the area extends onto the posterior aspect. 12. The brachioradialis arises from the upper two-thirds of the lateral supracondylar ridge. 13. The extensor carpi radialis longus arises from the lateral one-third of the lateral supracondylar ridge. The pronator teres, humeral head, arises from the lower one-third of the medial supracondylar ridge. The pronator teres, humeral head, arises from the lower one-third of the medial supracondylar ridge. The saprophacial flexor muscles of the forearm arise by a common origin from the anterior aspect of the medial epicondyle. This is called the common flexor origin. The superfacial extensor muscles of the forearm and supinator have a common origin from the lateral epicondyle. This is called the common extensor origin. The anconus, Greek elbow, arises from the posterior surface of the lateral epicondyle. Lateral head of triceps brachii arises from oblique ridge on the upper part of posterior surface above the radial groove, while its medial head arises from posterior surface below the radial grooves. The capsular ligament of the shoulder joint is attached to the anatomical neck except on the medial side where the line of attachment dips down by about 2 cm to include a small area of the shaft within the joint cavity. The line is interrupted at the intertubercular sulcus to provide an aperture through which the tendon of the long head of the biceps brachii leaves the joint cavity. The capsular ligament of the elbow/oinf is attached to the lower end along a line that reaches the upper limits of the radial and coronoid fossae anteriorly, and of the Olecranon fossa posteriorly, so that these fossae lie within the joint cavity. Medially, the line of attachment passes between the medial epicondyle and the trochlea. On the lateral side, it passes between the lateral epicondyle and the capitulum. 1, 2 to 3 nerves are directly related to the humerus and are, therefore, liable to injury. 1. The axillae at the surgical neck, 2. The radial at the radial groove, 3. The ulnar behind the medial epicondyle. The humerus ossifies from 1 primary center and 7 secondary centers. The primary center appears in the middle of the diaphysis during the 8th week of development. The upper end ossifies from 3 secondary centers, 1 for the head, 1st year, 1 for the greater tubercle, 2nd year, and 1 for the lesser tubercle, 5th year. The 3 centers fuse together during the 6th year to form 1 epiphysis, which fuses with the shaft during the 20th year. The epiphyseal line encircles the bone at the level of the lowest margin of the head. This is the growing end of the bone. Remember that the nutrient foramen is always directed away from the growing end. The lower end ossifies from 4 centers which form 2 epiphyses. The centers include 1 for the capitulum and the lateral flange of the trochlea, 1st year, 1 for the medial flange of the trochlea, 9th year, and 1 for the lateral epicondyle, 12th year. All 3 fuse during the 14th year to form 1 epiphysis, which fuses with the shaft at about 16 years. The center for the medial epicondyle appears during 4-6 years, forms a separate epiphysis, and fuses with the shaft during the 20th year. The common sites of fracture of humerus are the surgical neck, the shaft, and the supracondylar region. Supracondylar fracture is common in young age. It is produced by a fall on the outstretched hand. The lower fragment is mostly displaced backwards, so that the elbow is unduly prominent, as in dislocation of the elbow joint. This fracture may cause injury to the median nerve. It may also lead to Focrian Rees ischemic contracture caused by occlusion of the brachial artery. The three bony points of the normal elbow form the equilateral triangle in a flexed elbow and are in one line in an extended elbow. The humerus has a poor blood supply at the junction of its upper and middle thirds. Fractures at this site show delayed union or non-union. The head of the humerus commonly dislocates inferiorly. Radius. The radius is the lateral bone of the forearm, and is homologous with the tibia of the lower limb. It has an upper end, a lower end and a shaft. Side determination. One upper end is having disc-shaped head while lower end is expanded with a styloid process. 2. At the lower end, the anterior surface is in the form of thick prominent ridge, while the posterior surface presents 4 grooves for the extensor tendons. 3. The sharpest border of the shaft is the medial border. Close to neck it presents a radial tuberosity. 4. Lower end presents a tubercle on the posterior surface called as dorsal tubercle of Lister. Features. Upper end. 1. The head is disc-shaped and is covered with hyaline cartilage. It has a superior concave surface which articulates with the capitulum of the humerus at the elbow joint. The circumference of the head is also articular. It fits into a socket formed by the radial notch of the ulna and the urine flow/or ligament, thus forming the superior radio-ulnar joint. 2. The neck is enclosed by the narrow lower margin of the annular ligament. The head and neck are free from capsular attachment and can rotate freely within the socket. 3. The tuberosity lies just below the medial part of the neck. It has a rough posterior part and a smooth anterior part. It has 3 borders and 3 surfaces. 1. The anterior border extends from the anterior margin of the radial tuberosity to the styloid process. It is oblique in the upper half of the shaft, and vertical in the lower half. The oblique part is called the anterior oblique line. The lower vertical part is crest-like. 2. The posterior border is the mirror image of the anterior border, but is clearly defined only in its middle 1/3. The upper oblique part is known as the posterior oblique lines. 3. The medial or interosseous border is the sharpest of the 3 borders. It extends from the radial tuberosity above to the posterior margin of the ulnar notch below. The interosseous membrane is attached to its lower 3/4. In its lower part, it forms the posterior margin of an elongated triangular area. Surfaces. 1. The anterior surface lies between the anterior and interosseous borders. A nutrient foramen opens in its upper part, and is directed upwards. The nutrient artery is a branch of the anterior interosseous artery, Fig 2.23. 2. The posterior surface lies between the posterior and interosseous borders. 3. The lateral surface lies between the anterior and posterior borders. It shows a roughened area in its middle part. Lower end. It is the widest part of the bone. It has 5 surfaces. 1. The anterior surfaces is in the form of a thick 2, prominent ridge. The radial artery is palpated against this surface. The posterior surface presents 4 grooves for the extensor tendons. The dorsal tubercle of Lister lies lateral to an oblique groove, Fig 2.22. 3. The medial surface is occupied by the ulnar notch for the head of the ulna. 4. The lateral surface is prolonged down to form the styloid process. 5. The inferior surface bears a triangular area for the scaphoid bone, and a medial quadrangular area for the lunate bone. This surface takes part in forming the wrist joint. Attachments. 1. The biceps, Latin 2 heads, brachii is inserted into the rough posterior part of the radial tuberosity. The anterior part 1. The tuberosity is covered by a bursa. 2. The supinator, Latin to bend back, is inserted into the upper part of the lateral surface. 3. The pronator teres is inserted into the middle of the lateral surface. 4. The Radialis is inserted into the lowest part 1. The lateral surface just above the styloid process. 6. The radial head of the flexor digitorum superficialis. 5. Takes origin from the anterior oblique line and the upper part of anterior border. The flexor pollicis, Latin thumb, longus takes origin from the upper 2/3 of the anterior surface. 6. The pronator quadratus is inserted into the lower part of the anterior surface and into the triangular area on the medial side of the lower end. The radial artery is palpated for radial pulse as it lies medial to the sharp anterior border of radius, lateral to the tendon of flexor carpi radialis, Fig 2.25. 7. The abductor pollicis forges and the extensor pollicis brevis arise from the posterior surface. 5. The quadrate ligament is attached to the medial part of the neck. 6. The oblique cord attached on the medial side just below the radial tuberosity. 8. The articular capsule of the wrist joint is attached to the anterior and posterior margins of the inferior articular surface. 9. The articular disc of the inferior radio-ulnar joint is attached to the lower border O1 the ulnar notch. 10. The extensor retinaculum is attached to the lower part of the anterior border. 11. The interosseous membrane is attached to the lower 3/4 of the interosseous border. 7.15 The first groove between crest-like lowest part of anterior border and styloid process gives passage to Adductor Pollicis longus and Extensor poi/isis brevis. 16 The second groove between styloid process and dorsal tubercle gives way to Extensor rarpi rhodiolis longus and Extensor carpi radialis brevis tendons. 17 The third oblique groove medial to dorsal tubercle gives passage to Extensor pollicis longus tendon. 18 The fourth groove on the medial aspect gives passage to tendons of Extensor digitorum, Extensor indites, posterior interosseous nerve and anterior interosseous artery. 19 In addition at the junction of lower ends of radius and ulna, passes the tendon of Extensor digiti minimi. 20 Lastly in relation to ulna, between its head and styloid process traverses the tendon of Extensor carpi ulnaris. These are 6 compartments under Extensor retinaculum of wrist, 4 are in relation to radius, 5th at the junction of radius and ulna and 6th on the ulna itself between its head and styloid process. The shaft ossifies from a primary center which appears during the 8th week of development. The lower end ossifies from a secondary center which appears during the 1st year and fuses at 20 years, it is the growing end of the bone. The upper end, head, ossifies from a secondary center which appears during the 4th year and fuses at 18 years. The radius commonly gets fractured about 2 cm above its lower end, Colles fracture. This fracture is caused by a fall on the outstretched hand, Fig 2.28a. The distal fragment is displaced upwards and backwards, and the radial styloid process comes to lie proximal to the ulnar styloid process. It normally lies distal to the ulnar styloid process. If the distal fragment gets displaced anteriorly, it is called Smith's fracture, Fig 2.28b. A sudden powerful jerk on the hand of child may dislodge the head of the radius from the grip of the annular ligament. This is known as subluxation of the head of the radius, pulled elbow. The head can commonly be felt in a hollow behind the lateral epicondyle of the humerus. The ulna. The ulna is the medial bone of the forearm, and is homologous with the fibula of the lower limb. It has upper end, shaft, and a lower end. Side determination. 1. The upper end is hook-like, with its concavity directed forwards. 2. The lateral border of the shaft is sharp and crest-like. 3. Pointed styloid process lies posteromedial to the rounded head of ulna at its lower end. Features. Upper end. The upper end presents the Olecranon and coronoid processes, and the trochlear and radial notches. 1. The Olecranon process projects upwards from the shaft. It has superior, anterior, posterior, medial, and lateral surfaces. The anterior SBR/ACE is articular, it forms the upper part of the trochlear notch. The posterior surface forms a triangular subcutaneous area which is separated from the skin by bursa. Humeri it is continuous with the posterior border of the shaft of the ulna. The upper part forms the point of the elbow. The medial surface is continuous anteriorly with the medial surface of the shaft. The lateral surface is smooth, continues as posterior surface of shaft. The superior surface in its posterior part shows a roughened area. 1. The coronoid, Greek like crow's beak, process projects forwards from the shaft just below the olecranon and has 4 surfaces, namely superior, anterior, medial and lateral. The superior surface forms the lower part of the trochlear notch. The inferior surface is triangular and rough. Its lower corner forms the ulnar tuberosity. The upper part of its lateral surface is marked by the radial notch for the head of the radius. The annular ligament is attached to the anterior and posterior margins of the notch. The lower part of the lateral surface forms a depressed area to accommodate the radial tuberosity. It is limited behind by a ridge called the spinafor crest. Radial surface is continuous with medial surface of the shaft. 2. The trochlear notch forms an articular surface that articulates with the trochlea of the humerus to form the elbow joint. 4. The radial notch articulates with the head of the radius to form the superior radio-ulnar joint. Shaft. The shaft has 3 borders and 3 surfaces. Borders. 1. The interosseous or lateral border is sharpest in its middle 2/4. Inferiorly, it can be traced to the lateral side of the head. Superiorly, it is continuous with the supinator crest. 2. The anterior border is thick and rounded. It begins above on the medial side of the ulnar tuberosity, passes backwards in its lower 1/3, and terminates at the medial side of the styloid process. 3. The posterior border is subcutaneous. It begins, above, at the apex of the triangular subcutaneous area at the back of the olecranon, and terminates at the base of the styloid process. Surfaces. The anterior surface lies between the anterior and interosseous borders. A nutrient foramen is seen on the upper part of this surface. It is directed upwards interosseous artery. 2. The medial SXR/ACE lies between the anterior and posterior borders. 3. The posterior surface lies between the posterior and interosseous borders. It is subdivided into 3 areas by 2 lines. An oblique line divides it into upper and lower parts. The lower part is further divided by a vertical line into a medial and a lateral area. The lower end is made up of the head and the styloid process. The head articulates with the ulnar notch of the radius to form the inferior radio-ulnar joint. It is separated from the wrist joint by the articular disc. Ulnar artery and nerve lie on the anterior aspect O1 head of ulna. The styloid process projects downwards from posteromedial side of lower end of the ulna. Posteriorly, between the head and the styloid process, there is groove for the extensor carpi ulnaris attachments. 1. The forceps brachii is inserted into the rough posterior part of the superior surface of the olecranon. The anterior part of the surface is covered by a bursa. Interosseous artery. 4. The medial surface lies between the anterior and posterior borders. 5. The posterior surface lies between the posterior and interosseous borders. It is subdivided into 3 areas by 2 lines. An oblique line divides it into upper and lower parts. The lower part is further divided by a vertical line into a medial and a lateral area. The lower end. The lower end is made up of the head and the styloid process. The head articulates with the ulnar notch of the radius to form the inferior radio-ulnar joint. It is separated from the wrist joint by the articular disc. Ulnar artery and nerve lie on the anterior aspect of head of ulna. The styloid process projects downwards from posteromedial side of lower end of the ulna. Posteriorly, between the head and the styloid process, there is groove for the tendon of the extensor carpi ulnaris. Attachments. 1. The forceps brachii is inserted into the rough posterior part of the superior surface of the olecranon. The anterior part of the surface is covered by a bursa. 2. The brachialis is inserted into the anterior surface of the coronoid process including the tuberosity of the ulna. 3. The supinator arises from the supinator crest and from the triangular area in front of the crest. 4. The ulnar head of the flexor digitorum superficialis arises from a tubercle at the upper end of the medial margin of the coronoid process. 5. The ulnar head of the pronator furs arises from the medial margin of the coronoid process. 6. The flexor digitorum profundus, Latin deep, arises from the upper 3/4 of the anterior and medial surfaces of the shaft. The medial surfaces of the coronoid and olecranon processes. The posterior border of the shaft through an aponeurosis which also gives origin to the flexor carpi ulnaris and the extensor carpi ulnaris. 7. The pronator quadratus takes origin from the oblique ridge on the lower part of the anterior surface. 8. The flexor carpi ulnaris, ulnar head, arises from the medial side of the olecranon process and from the posterior border. 10. The extensor carpi ulnaris arises from the posterior border. 11. The anconus is inserted into the lateral aspect of the olecranon process and the upper 1/4 of the posterior surface of the shaft. The lateral part of the posterior surface gives origin from above downwards to the Adductor Pollicis longus, the Extensor Pophlysis forgis and the Extensor indicis. 13. The interosseous membrane is attached to the interosseous border. 12. The oblique cord is attached to the ulnar tuberosity. 13. The capsular ligament of the elbow joint is attached to the margins of the trochlear notch, i.e. to the coronoid and olecranon processes. 14. The circular ligament of the superior radio-ulnar joint is attached to the two margins of radial notch of ulna. 15. The ulnar collateral ligament of the wrist is attached to the styloid process. 16. The articular disc of the inferior radio-ulnar joint is attached by its apex to a small rough area just lateral to the styloid process. 17. The shaft and most of the upper end ossify from a primary center which appears during the 8th week of development. The superior part of the olecranon process ossifies from a secondary center which appears during the 10th year. It forms a scale-like epiphysis which joins the rest of the bone by 16th year. The lower end ossifies from a secondary center which appears during the 5th year, and joins with the shaft by 18th year. This is the growing end of the bone. The ulna is the stabilizing bone of the forearm, with its trochlear notch gripping the lower end O1 the humerus. On this foundation, the radius can pronate and supinate for efficient working of the upper limb. The shaft of the ulna may fracture either alone or along with that of the radius. Cross-union between the radius and ulna must be prevented to preserve pronation and supination O1 the hand. Dislocation of the elbow is produced by a fall on the outstretched hand with the elbow slightly flexed. The olecranon shifts posteriorly and the elbow is fixed in slight flexion. Normally in an extended elbow, the tip of the olecranon lies in a horizontal line with the two epicondyles of the humerus, and in the flexed elbow, Fig 2.19, the three bony points form an equilateral triangle. These relations are disturbed in dislocation of the elbow. Fracture of the olecranon is common and is caused by a fall on the point of the elbow. Fracture of the coronoid process is uncommon, and usually accompanies dislocation of the elbow. Mode Longus deformity is dorsal subluxation, displacement, of the lower end O1 the ulna, due to retarded growth of the lower end of the radius. Ossification of humerus, radius, and ulna. Law of ossification. In long bones possessing epiphyses at both their ends, the epiphysis of that end which appears first is last to join with the shaft. As a corollary, epiphysis which appears last is first to join. These ends of long bones which unite last with the shaft are designated as growing end of the bone. In case of long bones of the upper limb, growing ends are at shoulder and wrist joints. This implies that, the upper end of humerus arid lower ends of both radius and ulna are growing ends, and each will, therefore, unite with their shaft at a later period than their corresponding other ends. The direction of the nutrient foramen in these bones, as a rule, is opposite to the growing end. The time of appearance and fusion, either or various parts at one end, or with the shaft, are given in Table 2.1. Attachments and epiphyseal line. Metaphysis is the epiphyseal end of the diaphysis. It is actively growing part of the bone with rich blood supply. Infections in this part of the bone are most common in the young age. The epiphyseal line is the line of union of metaphysis with the epiphysis. At the end of the bone, besides the epiphyseal line is the attachment of the capsule of the respective joints. So infection in the joint may affect the metaphysis of the bone if it is partly or completely inside the joint capsule. As a corollary, the disease of the metaphysis if inside a joint may affect the joint. So it is worthwhile to know the intimate relation of the capsular attachment and the epiphyseal line at the ends of humeral, radial, and ulnar bones as shown in Table 2.2. Relation of capsular attachments and epiphyseal lines. If epiphyseal line, i.e. site of union of epiphysis and metaphyseal end of diaphysis, is intracapsular, the infections of the joints are likely to affect the metaphysis, the actively growing part of the bone especially in young age. The carpus is, Greek karpos, wrist, made up of 8 carpal bones, which are arranged in 2 rows. The proximal row contains, from lateral to medial side the scaphoid, Greek hoof, wrist, the lunate, Latin moon shafor, the triquetra, Latin 3-cornered, and the pisiform, Greek pen. 2. The distal row contains in the same order, the trapezium, Greek / lower-sided geometric figure, the trapezoid, Greek hohies shoe, the capitate, Latin head, and the hamate, Latin hook. Identification 1. The scaphoid is boat-shaped and has a tubercle on its lateral side. 2. The innate is half-moon-shaped or crescentic. 3. The triquetra is pyramidal in shape and has an isolated oval facet on the distal part of the pulvinar surface. 4. The pisiform is P-shaped and has only one oval facet on the proximal part of its dorsal surface. 5. The trapezium is quadrangular in shape, and has a crest and a groove anteriorly. It has a sellar, concavo-convex, articular surface distally. 6. The trapezoid resembles the shoe of a baby. 7. The capitate is the largest carpal bone, with a rounded head. 8. The hamate is wedge-shaped with a hook near its base. Side determination. General points. 1. The proximal row is convex proximally, and concave distally. 2. The distal row is convex proximally and flat distally. 3. Each bone has 6 surfaces. The pulvinar and dorsal surfaces are non-articular, except for the triquetra and pisiform. The lateral surfaces of the 2 lateral bones, scaphoid and trapezium, are non-articular. The medial surfaces of the 3 medial bones, triquetra, pisiform, and hamate, are non-articular. 4. The dorsal non-articular surface is always larger than the pulvinar non-articular surface, except for the lunate, in which the pulvinar surface is larger than the dorsal. The general points help in identifying the proximal, distal, pulvinar, and dorsal surfaces in most of the bones. The side can be finally determined with the help of the specific points. Specific points. 1. The scaphoid, the tubercle is directed laterally, forward, and downwards. 2. Lunate. 2. A small semilunar articular surface for the scaphoid is on the lateral side. A quadrilateral articular surface for the triquetra is on the medial side. 3. The triquetra. The oval facet for the pisiform lies on the distal part of the pulvinar surface. The medial and dorsal surfaces are continuous and non-articular. 4. Pisiform. The oval facet for the triquetra lies on the proximal part of the dorsal surface. The lateral surface is grooved by the ulnar nerve. 4. The trapezium. The pulvinar surface has a vertical groove for the tendon of the flexor carpi radialis. The groove is limited laterally by the crest of the trapezium. The distal surface bears a sellar concavo-convex articular surface for the base of the first metacarpal bone. 4. The trapezoid. The distal articular surface is bigger than the proximal. The pulvinar non-articular surface is prolonged laterally. The capitate, the dorsomedial is the distal-most projection from the body of the capitate. It bears the homoph, the hook projects from the distal part of the pulvinar surface and is directed laterally. Attachments, there are 4 bony pillars at the 4 corners of the carpus. All attachments are to these 4 pillars. 1. The tubercle of the scaphoid, the flexor retinaculum, a few fibers of the Adductor Pollicis brevis. 2. The pisiform gives, flexor carpi ulnaris, flexor retinaculum, and its superficial slip, abductor digiti mertimi, extensor retinaculum. 3. The trapezium and capitates, flexor pollicis brevis, and opponens pollicis. These constitute muscles of thenar eminence. 2 layers of the /exoretinaculum ligament of the wrist joint. 3. The lateral surface gives attachment to the lateral ligament of the wrist joint. Radialis. The hamate, the tip of the hook gives attachment to their foretinaculum. The medial side of the hook gives attachment to the flexor digiti minimi and the opponens digiti maemi. Articulations 1. The scaphoid, radius, lunate, trapezium, trapezoid capitate, Fig 2.34. 2. The lunate, radius, scaphoid, capitate, hamate, and triquetra. 3. The triquetrial pisiform. Lunate hamate and auricular disc of the interradi-minor joint. 3. The pisiform articulate only with the triquetra. The pisiform articulates only with triquetra. The trapezium scaphoid, first and second metacarpals. 2. Trapezoid, scaphoid trapezium. 2 and D metacarpal. The crest gives origin to the adductor pollicis brevis, the capitate, scaphoid, lunate, hamate, second, third and 4th metacarpals and trapezoid. 5th metacarpals. The year of appearance of center of ossification in the carpal bones is shown in Figs 2.35a and b. Fracture of the scaphoid is quite common. The bone fractures through the waist at right angles to its long axis. The fracture is caused by a fall on the outstretched hand, or on the tips of the fingers. This causes tenderness and swelling in the anatomical snuff box, and pain on longitudinal percussion of the thumb and index finger. The residual disability is more marked in the midcarpal joint than in the wrist joint. The importance of the fracture lies in its liability to nonurion, and avascular necrosis of the body of the bone. Normally, the scaphoid has 2 nutrient arteries, one entering the pulvinar surface of the tubercle and the other the dorsal surface of the body. Occasionally, 13% of cases, both vessels enter through the tubercle or through the distal half of the bone. In such cases, fracture may deprive the proximal half of the bone of its blood supply, leading to avascular necrosis, Fig 2.36. Dislocation of the lunate may be produced by a fall on the acutely dorsiflexed hand with the elbow joint flexed. This displaces the lunate anteriorly, also leading IOCDT pal funnel syndrome-like features, Figs 2.37a to c. During scaphoid fracture, pain is felt in the anatomical snuff box. Metacarpal bones. The metacarpal bones are 5 miniature long bones, which are numbered from lateral to the medial side. Each bone has a head placed distally, a shaft and a base at the proximal end. The head is round. It has an articular surface which extends more anteroposteriorly than laterally. It extends more on the pulvinar surface than on the dorsal surface. The heads of the metacarpal bones form the knuckles. The shaft is concave on the pulvinar surface. Its dorsal surface bears a flat triangular area in its distal part. The base is irregularly expanded. 3. A metacarpal bone can be distinguished from a metatarsal bone because of the differences given in Table 2.3. Characteristics of individual metacarpal bones. First A. It is the shortest and stoutest of all metacarpal bones, Fig 2.38a. The base is occupied by a convexo-concave articular surface for the trapezium. The dorsal surface of the shaft is uniformly convex, Fig 2.38b. The head is less convex and broader from side to side than the heads of other metacarpals. The ulnar and radial corners of the pulvinar surface show impressions for sesamoid bones. The first metacarpal bone is rotated medially through 90 degrees relative to the other metacarpals. As a result of this rotation, the movements of the thumb take place at right angles to those of other digits. 1. It does not articulate with any other metacarpal bone. 2. The base is grooved from before backwards. The medial edge of the groove is larger. 3. The base has a styloid process projecting up from the dorsolateral corner. 4. The base has 2 small oval facets on its lateral side for the third metacarpal, and on its medial side it has a single elongated facet for the fifth metacarpal. 5. The base has an elongated articular strip on its lateral side for the fourth metacarpal. The medial side of the base is non-articular and bears a tubercle. Side determination. 6. The proximal, distal, palmar, and dorsal aspects of each metacarpal bone can be made out from what has been stated above. The lateral and medial sides can be confirmed by the following criteria. Metacarpal, first, the anterolateral surface is larger than the anteromedial. Second, the medial edge of the groove on the base is deeper than the lateral edge. B. The medial side of the base bears an articular strip which is constricted in the middle. 7. The styloid process is dorsolateral. B. The lateral side of the base bears an articular strip which is constricted in the middle. C. The medial side of the base has two small oval facets for the fourth metacarpal. 4. The lateral side of the base has two small oval facets for the third metacarpal. B. The medial side of the base has an elongated articular strip for the fifth metacarpal. 5. The lateral side of the base has an elongated articular strip for the fourth metacarpal. B. The medial side of the base is non-articular and has a tubercle. Main attachment. The main attachments from shaft of metacarpals is of palmar and dorsal interossei muscles. Palmar interossei arise from one bone each except the third metacarpal, Fig. 2.38a. Dorsal interossei arise from adjacent sides of two metacarpals, Fig. 2.38b. The other attachments are listed below. Metacarpal. First, the Acromion pollicis is inserted on the radial border and the anterolateral surface of the shaft. B. The Adductor Pollicis longus is inserted on the lateral side of the base. C. The first palmar interosseous muscle arises from the ulnar side of the base. Second, the extensor Carpi radialis is inserted on a tubercle on the palmar surface of the base. B. The extensor Carpi radialis longus is inserted on the dorsal surface of the base. C. The oblique head of the Adductor Pollicis arises from the palmar surface of the base. Third, a slip from the extensor Carpi radialis is inserted on the palmar surface of the base. The extensor Carpi radialis Humerus is inserted on the dorsal surface of the base, immediately beyond the styloid process. The oblique head of the Adductor Pollicis arises from the palmar surface or the base. The transverse head of the Adductor Pollicis arises from the distal 2/3 of the palmar surface of the shaft. Fourth, only the interossei arise from it. Fifth, the extensor Carpi ulnaris is inserted on the tubercle at the base. B. The opponens digiti minimi is inserted on the medial surface of the shaft. Articulations at the bases. First, with the trapezium forms saddle-shaped joint. Second, with the trapezium, the trapezoid, the capitates and the third metacarpal. And the third metacarpal. Third, with the capitate and the second and fourth metacarpals. Fourth, with the capitate, the hamate, and the third and fifth metacarpals. Fifth, with the hamate and the fourth metacarpal. The shafts ossify from one primary center each, which appears during the 9th week of development. A secondary center for the head appears in the 2 and 5th metacarpals, and for the base in the first metacarpal. It appears during the 2 and 3rd year and fuses with the shaft at about 16-18 years. Fracture of the base of the first metacarpal is called Bennett's fracture. It involves the anterior part of the base, and is caused by a force along its long axis. The thumb is forced into a semi-flexed position and cannot be opposed. The fist cannot be clenched. The other metacarpals may also be fractured by direct or indirect violence. Direct violence usually displaces the fractured segment forwards. Indirect violence displaces them backwards. Tubercular or syphilitic disease of the metacarpals or phalanges in a child is located in the middle of the diaphysis rather than in the metaphysis because the nutrient artery breaks up into a plexus immediately upon reaching the medullary cavity. In adults, however, the chances of infection are minimized because the nutrient artery is replaced, as the major source of supply, by periosteal vessels. When the thumb possesses 3 phalanges, the first metacarpal has 2 epiphyses, one at each end. Occasionally, the first metacarpal bifurcates distally. Then the medial branch has no distal epiphysis, and has only 2 phalanges. The lateral branch has a distal epiphysis and 3 phalanges. Total digits are 6 in such case. Less frequently, there is a sesamoid bone on the lateral side of the metacarpophalangeal joint of the index finger. Sometimes sesamoid bone may be found at other metacarpophalangeal joints. Mnemonics. Carpal bones. She looks too pretty tired to catch her. Lateral / to medial, proximal row. Scaphoid. Lunate. Triquetra. Pisiform. Distal row. Trapezium. Trapezoid. Capitate. Hamate. Elbow, which side has common flexor? Flexor medial, so common flexor origin is on the medial side. Bidigital groove of humerus, lady between 2 majors, lateral lip pectoralis major. Medial lip teres major. Floor, latissimus dorsi. Axillary radial and ulnar nerves are intimately related to humerus and are liable to be injured. Radial pulse is felt close to the lower end of shaft of radius. Pisiform bone is a sesamoid bone in the tendon of flexor carpi ulnaris muscle. First metacarpal is the shortest, and strongest of metacarpals. It is situated at an angle to the other bones, this permitting opposition of the thumb. Third metacarpal is the longest and the axis of abduction and adduction passes through its center.